very good afternoon and a very good evening wherever you are in this world. And welcome to this wonderful session that we've got for you today. And the topic of the session is Bridging Healthcare Divide, Empowering Rural and Remote Areas Through Telemedicine and Innovative Health Solutions. Today, we know that the world is actually grappling with a very serious problem, which is about disparities in health access and healthcare access and services. And the divide is even more larger when we compare the urban and the rural or remote areas. This initiative and the panel will be focused on telemedicine, which involves technologies such as video calls, which are very simple, and digital communication to provide medical care and consultations remotely. It also involves the implementation of innovative healthcare solutions to overcome challenges faced by the underserved areas in accessing quality healthcare. The panel is also going to be focusing on how remote and rural locations and are connected to medical professionals that are largely located in the urban areas. Patients, even in these urban underserved areas, now can kind of receive medical advice, consultations, and even diagnosis through digital means. The goal is to provide healthcare services to those who are geographically isolated and lack access to the medical facilities. We would also kind of talk about mobile clinics, health apps, and also remote monitoring devices and community health workers to enhance the healthcare delivery in remote regions. The overall aim, as the topic says, is to bridge gap in healthcare services and to improve health outcomes of the individuals living in rural and remote areas. Whatever is happening here today has implications for all over the world, specifically if you look at the third world countries and the countries that are still in the development mode, where the digital divide is also impacting access to healthcare. With that as an introduction, I would turn it over to Dr. Vani Ahluwalia, who's a practicing doctor and presently a medical officer of ART Jabalpur under NACO and is the National Secretary of Arogya. So over to you, Vani, to first introduce Ekal Arogya and then the initiative.
Thank you so much, Dr. Singh Mishra. Namaskar to all of you viewers. So India is a country of diversity and is constantly evolving. Here in India, what we are working with is the Ekal Abhiyan, a charismatic Abhiyan. Ekal Abhiyan is a tradition which works on a holistic plan, and we include Bal Shiksha, that is education with children, Gram Shiksha and Gram Utthan, elevating the level of village lifestyles, village livelihood. Jagran Sanskar Shiksha, connecting these villagers to their roots, to all their sanskar and their value system. And the fifth part of the Abhiyan is Arogya, that is the medicine part, the part that deals with preventive health care. Arogya Foundation of India is our parent body which empowers the Ekal Arogya Prakalp to work in the villages, on the ground, in the rural setup only. Please take note that Ekal Arogya Prakalp does not work in the urban settings. Our primary work is in the area of preventive health care, initiatives of sanitation, lifestyle diseases, nutrition, home remedies, first aid, and what we have included now as an important milestone is telemedicine. We have evolved and involved technology with the dispersal of healthcare to the remotest of remote areas in the country. You're very well aware that many parts of India are not accessible easily to even the government setups. That's where we act as a bridge. We act as a bridge for these villagers to improve their health oriented lifestyles, to connect with modern medicine, and to improve their social value systems. All this involves a setup. Our basic setup involves 30 villages. I will give you a brief um, background so that it takes you further in understanding. So, we work on a setup of about 30 villages. Each village is monitored by a health sevika. She's like a health assistant. She's an empowered lady from the village who's been trained by us to handle all her social causes, to monitor the health outlook in that village, to sustain the social standards in that village. And now she is also the role model for telemedicine. This Sevika is conversant in a little bit of English, fluent in Hindi, and absolutely well conversant with the local traditions. We believe that prevention is better than cure. So, health and sanitation, though they are the center stage for all our programs, and we concentrate on this because this is what leads to the maintenance of good health. We work on disease prevention by making soak pits, by facilitating good garbage disposal facilities, discouraging open air defecation, encouraging good hygiene hand practices, and constantly upgrading the village in a conversation which involves a lot of posters and a lot of uh, conversation methods. They may be by taking out processions, by talking to individual families. This Sevika also maintains a record of the entire village. She knows house to house in her survey how many people exist in a family, what is the composition, what is the health status, what is the medication, who's ill, if there is a cancer patient, if there is anyone who is having any addiction problem. We believe that you are what you eat. So the Sevika also channelizes her dispersal of good knowledge to the villagers by way of inculcating a habit of growing a nutritional garden and a these become pillars for the villagers to fall back on in case of any ailment. They have common home remedies to rely on. Now we've created an internode. This internode is educating all our karyakartas and at the same time empowering the simple villager who cannot go out and meet his needs, which he needs to cater to his health needs. So, what we are doing is we are also helping the government. The government is making a policy, but policy implementation becomes equally vital and important in this area. So, when we talk about in Hinduism, when we talk about achar, vichar, vyavhar, and ahar, we are putting the behavior, thoughts, attitude, and nutrition along with technology of telemedicine into one basket. And that's how we are tackling the current social problems that are afflicting our societies in the rural parts of the country. Now, I would really believe that if you're not solving these current problems, then you can't move ahead. And a country would only be known by the development in the villages, cities are self-sustaining. I would now request my colleague Dr. Manish Singh, who is a dentist by profession, but he's devoted his time and energy. He's a full-timer with us at Ekal Arogya Prakalp, and he is our national training coordinator who moves around the entire country. He's traveling even today. I would now like him to give us a small talk on how we started the telemedicine journey. I also welcome our president of Ekal Arogya Prakalp, Dr. R.N. Mehta, who's a retired CMHO and civil surgeon. He is an anesthetist by profession, and he is again post retirement devoting all his time to the activity, to monitoring, and to channelizing the work of Ekal Arogya Prakalp, which is now spearheading to about 1,500 villages across the country. Welcome, Dr. Mehta. Over to you, Dr. Manish.
Uh, thank you, ma'am. Actually, the timeline started from the uh, COVID, as there is a said that necessity is the mother of all invention, and when the it's always says when tough gets going, uh, going gets tough, tough get going. So we when COVID hit us, hit the nation, and we were in our what you say in the peak of the COVID period. The our work, whatever ma'am has told that our work, you will be noticing that required any physical intervention. So in COVID, that physical intervention was a very difficult task to us. And
Apparently, I think there's a connectivity issue and Manish is frozen. So, COVID was a difficult task, and COVID was not what we could really imagine. In the rural areas and some setups, uh, villagers could not even go to the nearest health block to seek uh, any kind of help and support. And it is then that we um, came up with a strategy, and we started contacting these villages where we work and the adjacent villages with protocols and with directions on how they need to monitor and get themselves health safe. What started as an experiment during the COVID, um the second COVID wave, was very successful, and that is what prompted us after the second wave of COVID to develop an app with another partner. Hi, Manish, you're back. You can take it on from now and you can start talking on your app and how it developed after the second wave.
we started a helpline with the same vendor. With afterwards, with we developed the telemedicine app. So we developed a helpline number and started doing helpline consultations to the patient through call connected through WebRTC to the doctor, and that became very successful for us because around about 15,000 patients were benefited from that COVID helpline. And then after that COVID helpline finished, we saw that there are many post-COVID complications were also present. So we started another helpline that was called post-COVID helpline and by the name Swasthya Sampark. So after all the success of both the helplines, we decided to move it forward and do it physically when the physical work was allowed to do us. So we started to developing that helpline, and we started to collect all the data what most of the people are suffering from in the villages, and then we started to develop that what we say mind map for all that symptoms, and we develop all the mind map, whatever the questions that the doctor could ask. We thoroughly sit on that for 7 days. We did a 7-day workshop on that, and we develop all the mind map with the question that can be asked by a doctor, and all the questions were fitted with that respective symptoms. And then we also developed that whatever the vitals could be required for that any particular type of symptoms. As we are also focusing on lifestyle diseases, so we included all the hemoglobin and sugar test also, that somebody if you wanted to do that, that can also be included in that app. So all through all app, all when all the things were developed, we started to we proposed a training how to we will do the training, how because the end worker is a 10th or 12th pass married lady, and giving that medical knowledge to that non-medico will be a difficult task to us. So we decided that we will create internodes, and through that internodes the knowledge will pass. And so we decided first to all our karkarta to develop that skill, and to transfer that knowledge to the ground. But before transferring the knowledge, we uh, decided that all many skills are required to before transferring the knowledge, that is technical knowledge, technology. And we divided that all the knowledge into four parts: technical knowledge, technological knowledge, communication knowledge, and management knowledge, because technical knowledge is required for that medical part and all the things that we are required in this app. Technological, because app is itself a little bit of technology. Maybe we as a urban people don't take that app as a difficult part, but for a village to learn a app is a little bit a very difficult task. So we also give them a technological training and make them technologically sufficient. Because if any troubleshoot come from this app, they can troubleshoot in from the field itself. Then third one is the communication skill, because if you learn everything but you can't transfer it to the ground, so nothing will be there. So we also ensure that they have a right communication skill, so that they can transfer it to the field, to the ground worker. And fourth one is the management, because field encounters many problems. So we have to balance the situations, balance the person, because each person is a different aspect. And there is a very famous saying, and that the doctor who manages chairside better is a better doctor than who treats well. So how the chairside behavior should be there, so that is very also important aspect. So we also teach them how to maintain a behavior with a patient. So all the teaching, after all the teaching and through notes and the notes, we connected the sevikas, because on a large scale, because sevika is a 30, and we are working on around 1500 villages. So transferring that to 1500 villages just by single or 2-3%, it was becoming difficult. So we created that internodes, and we transferred all the knowledges. Then we started out rolling out the plan from December 2021. But again, a third wave of the corona, but that was not a severe part, but still it halted our work. So basically, we started it more of from March 2022 in a full-fledged way, and then we are still continuing it. And we are right now we have added round about eight out of 1500, we are round about added 870 villages, more 630 villages to be added. And we are also adding on villages also. So right now we are working on 200 villages. Also we have started our regular works, that is preventive work. So it will be now 630 plus 230 to we have a target to achieve till March 2024. So we will be adding that. And that's all from my side. This is a base brief timeline in brief how it works. We can explain it. Thank you.
Manish, I would also request you to update our viewers on the ease of operation of this app because a 10th or a 12th pass Sevika is going to use this app. It's like a cakewalk for her. She has no trouble in operating it. And I just want to make one mention that when we were training these Sevikas, you can imagine that they have no previous knowledge of anatomy and physiology, pathology. And we want them to behave just as certified health assistants. So we have actually been drawing diagrams of the human parts on the floor of the training hall. We've been time and again creating modules, charts, discourses, and even we have a retired orthopedic surgeon in our team, Dr. Mrityunjay, and he has even designed a syllabus for this. So this is to give you a brief layout. Manish, I would like you to now get on to how this app actually works in a few minutes. What
Okay.
happens if I'm the patient and you are the Sevika who has come to me?
Okay. First, whenever the patient comes to the Sevika, first she had already done a survey because before doing the patient, we have instructed Sevika to do the survey part, finish all the survey part, and the name, whoever the patient will come, the name will be already registered in that app. So he or she will be given a unique ID. Sevika can search that patient with that unique ID. So whenever she search that patient and she opened his or her profile, then she can start his making a visit. First, she has to take all the vitals. She has to record it, and she has to ask the patient about the symptoms. And symptoms, when she select the symptoms, there will be coming a mind map or the questions that can be asked. Each symptom required around about 8 to 9 questions. Sometimes it goes to 10 questions. What there is a protocol type of duration, site, mode of onset, progression, and after associated symptom relieving and giving and previous treatment done. All these questions are being asked in that app only. Sevika just have to ask whatever there is given in the app, and she will fill all the required details in that. Second, she has to also take the past medical history. There are questions set up from that for that. She has to also take that family history also, whatever is there. And second is she has to do a minimal physical examination, that is pickle, that is pallor, icterus, cyanosis, lymph node enlargement, and edema. So she has to take the basic physical, we teach them all that also. So after that, whenever that is finished, she usually send it to the cloud that we describe them as a upload. Whenever it is sent into the cloud, the doctor has a separate web app. Doctor can pick it up. The interesting part is of this app is Sevika can fill in her own languages, whatever it could be. We are working in 8 languages, and whatever language she will fill in, the history is shown in English to the doctor. And the doctor could open whenever the Sevika uploaded to the patient. The doctor can open that history. He or she can advise the patient, prescribe medicine, diagnosis, and all, and then he will do all the sign and submit. This whole process mostly takes the doctor part mostly takes 5 to 10 minutes, and then after all is done, Sevika has to download the prescription. There is an option in his app only, download the prescription, and when she will download, she will get all the prescription or the details in that, and she can share it on his number, patient phone number through WhatsApp or general message. That was also. One more development is there. If doctor uh, can can't understand some history, or he or she have some doubts, he can also call the Sevika through multiple options, because we have a protected doctor number. If doctor wants to protect his or her number, he can call through WebRTC, which is already developed in uh, which is already developed in the app. And if doctor is okay with his sharing his number. He can also call with his WhatsApp or a regular call. All the number is provided there. So whenever he can connect to the Sevika or the patient, and whatever doubts doctor is having, he or she can also clear that. After that, he can or she can give the prescription, and then patient Sevika can upload. One more option is there on Sevika. Sometimes some patients have already some tests done. Sevika can also.
Okay, looks like we lost Dr. Manish, but I think, if Dr. Vani, you can tell us
I'll
about
tell you.
the
I
impact.
would, yeah,
Yeah, sure.
I will want Manish to carry on with this topic. So I'm just going to take a little detour, and we have Dr. Mehta with us. So, Dr. Mehta, if you can just tell us about another aspect that we are working on. Oh, Dr. Mehta is also apparently dropped. Dr. Mehta,
Yeah,
the
I'm
connection
here.
is what it is.
I'm here.
Yes.
Yeah, Dr. Mehta, over to you. I want you to give in a little filler on and tell us on how we are working in 4 states with something that is absolutely connected with telemedicine and that is helping us in telemedicine, the iVans.
Yeah, uh, actually, in the field, we saw that the main problem arises with the vision. If vision is not proper, then person cannot see, and education and all the difficulties arises with the vision. So in the field, we are working with two eye vans, one in Jharkhand and other is in Rajasthan. And there we are examining the school-going kids as well as the all other population also, and we are providing them the specs also as per their numbers, and the numbers are being checked by our trained and qualified person. Optometrist is there. Similarly, now we have taken the two projects on pilot basis. One is in the Assam and other is in the Gujarat. That in that pilot project, we are going for the eye examination through the auto refractometer. It gives the number instantly there, and by that we are in the process of the providing the spectacles also. We started providing the specs. The specs are also free of cost, and it is being given with the help of the donors, this thing donation, and the child as well as the presbyopic, the old age, what we called after 40 years, for the reading glasses. These glasses are also we are providing. And similarly, along with this eye examination, when we get the cataract cases or other eye ailments, so cataract cases are being getting operated in the institutes where these are being operated, and those cataract cases are being taken care well, and the follow up is also being done with our the sevikas as well as our workers. So
Right.
this is the phenomena. It is going on for the eye activities.
Thank you so much, Dr. Mehta.
Thank you.
Uh, there is an aspect which is very important with telemedicine. Money saved is money earned. When an average villager goes to the next higher center, the closest town or the closest junction area to get to seek his health treatment, he always takes with him one attendant, and he spends about 4 to 5,000 rupees, Indian rupees, on his travel costs, food costs, treatment costs, and investigations. And very many a times they come back from that situation, that site, that location, because they run short of money and they are not able to complete. They're not able to even start their treatment. Now this is where our telemedicine app becomes economically friendly to these villagers. It saves them money, it saves them time. We give them access to the best doctors in the country free of cost. It is given to them at their doorstep. Along with this, the greatest advantage is that we are now beginning to map out areas of the absolutely remotest of remote villages in the country where even a cycle cyclists will not be able to go easily. And it takes these sevikas, these karyakartas of ours, an immense amount of motivation and connection with the ground, that they keep traveling for days on end to seek, people who need more health service. This is also acting in adjuvant um, to what the government is doing. As you know, that India has a very nice, a very comprehensive Ayushman Bharat scheme for the villagers, for people below the poverty line. So we are actually now becoming a bridge. We connect these villagers to the government schemes, because since the Sevika is carrying with her data from the village, she is able to comprehend, she is able to decipher, she is able to translate what is required for each household member. She is able to bring these government schemes to the doorstep of these villagers, along with the delivery of her health statistics monitoring. So, Dr. Manish, we missed you. Over to you again. I have just filled them up with sir has filled them up with the I-1. Oh, there seems to be a very bad connection. Manish is in Nasik and he's on the move. So please excuse us. Our young tech savvy dentist is always on the move for training these sevikas. Over to you, Manish. I have filled them up on the
Yes, ma'am.
linkage that the Sevika does for the government schemes, and we talked a little on the IVAN too.
Yes, ma'am. uh, as I always believe, there is what Mahatma Gandhi has already said, and I was always a believer in this. As I had a business background, I already left a well-established business just to fulfill that. Because when I joined this organization, I saw that whatever I wanted to do for the society, I can do. The first, whatever Mahatma Gandhi has already told, one step to woman and 10 steps to nation. If you teach a lady, you teach a whole family. If you teach a man, you teach just an individual. So I was very much involved in one more aspect, whatever telemedicine has offered me, that is women empowerment. As Sevika is not, I'll say, not taking money. She's just very less amount of service that is very affordable to a village person, just to make her confident, and just to say the patient that you have to take the medicine. Because some people, when say think that is free, sometimes they take it granted. So just we took that money, so that they don't take that treatment as granted. And that also, the money also will fulfill the Sevika basic needs for them. That will not make her financially independent, but just a basic need could be fulfilled, and she could contribute to her family. So that was also a issue from telemedicine that also I have encountered, and I focused on that. So the telemedicine also that offers them that the empowerment of the Sevika. And basically what I have seen many telemedicines out there, and I've already studied of telemedicine. What differentiation we had brought is, as what we have studied after before 30 years, our main patients were coming from communicable disease, and non-communicable diseases were very lesser part of that, lesser percentage of the whole total diseases. But right now, as of right now situation, the non-communicable diseases has become a larger part of all the diseases. So we have may focused our whole telemedicine on NCDs, or what do you say, lifestyle diseases. And yes, we are treating some basic diseases, and we have done it. And our main motto is also that the treatment of basic element on the field itself, so that it will not worsen, and also that will also decrease the workload of the already what will say work of the already overloaded hospitals, government setups, so that the right patient could get the right treatment. And yeah, we have already have some cases for them where we have encountered that cases that could that have, if not encountered as fast as possible, it could have become a worse situation. And there are some stories that because as a doctor, Dr. Mehta sir has encountered some stories of this. So I like Mehta sir to share, take 2 minutes and share those stories, what we have done it through. So, Dr. Mehta.
Yeah, during this dealing with the case on the this web app, I am actually working as a backend doctor also, along with running this program. So, in my experience of 5,000 plus cases, what I saw on this web, uh, hardly we take 7 to 10 minutes for a case to complete the history and seeing all these things. As the Manish said, the one thing I wanted to add in that thing that Sevika is filling up all these things uh, in her own language, that is the local language, but the history is going to the doctor in English. And doctor of in any area of the globe, he can see the history and he can give the opinion accordingly. So in one of the case, in the early morning, as per my practice, I got up in the early morning and I saw just how many cases are pending there. So immediately one case was uploaded of a snake bite. It was from the Madhya Pradesh in the interior village. That was a very remote village. So when I saw that snake bite, so I took that case immediately, and when I examined the history and found it that it was a serious case, and on calling to that Sevika and the relatives number, I could contact them and I sent that patient to the nearest hospital. There they gave the anti-snake venom. They gave more than 22 vials of anti-snake venom. That is a quite big dose. It is required for the management of this thing. And that lady is survived. So the telemedicine in the early morning, this is in the this type of activity in the remote areas, which helped a lot and saved a life. And the life of a lady is, as the empowerment is also important. Similarly, the her presence and her activities in the family is also that important. She was a mother of two small kids. So see the scenario that this telemedicine could help that family in that way. So this is our motto. One story. Similarly, one more story is like this only. During the helpline activities of COVID, one of the fellow from Jharkhand, Mr. Suresh Mishra, he was having pneumonitis and in the remote area. So that his case I saw, and I advise him treatment as per our telemedicine this uh, manual and this thing, and he got all right. When for the follow up after a month, I asked him how is he, is there any complication or anything. So I came to know that he was soliciting actually marriage of his daughter, and he was so emotional that he said that today I am getting this marriage done in front of me. My girl is being married today, and please give her blessings as you are just telemedicine saved our life. Thank you. Thank you, Manish.
I do believe that you also had treated a case of rabies.
Yeah, the third case, it was a from the Orissa in the remote area. A lady had a dog bite, rabid dog, and the rabid dog was there. And when she started early symptoms of this salivation and this disorientation, so on the this telemedicine, when I saw this case, I immediately referred that patient to the nearby infectious disease hospital, and that lady is also survived. So this is our success story of three cases of my only. So like me, there are more than 30 doctors are working with us actively presently. In our panel, we are having around 320 doctors, but presently we are active this much persons. And this is the my experience of this thing.
So, this is not just a success story, but this is victory for us, because this is actual rural empowerment. And the stories can go on, and the examples could just be never ending. But the beauty of all this is that when we talk about technology, we say technology is badass. But here, technology is a gift, it's a boon. And we're using this technology as a good servant to help us channelize our needs, to deliver what we have programmed, and to bring these women into the limelight. The way we have empowered these ordinary women, I must tell you about this. That before we had selected a few of these women, when we sent some other karyakartas to the village to do some surveys on whom we could choose, for these projects, the women opens the door at our house and we asked her, "Who's there at home?" We asked in the local dialect, "Kaun ghar pe hai?" And she said, "No one." So these women never even counted themselves as existent. And today their success stories are surmount on uh, empowerment, independence, and individuality. Dr. Manish, I'm sure you have something more to tell us about, a little bit more about this. And then we are going to just briefly touch on another small topic after Manish gives us a little information on this topic. Manish, don't go away now.
Thank you, ma'am.
Yeah, yeah,
Is
yeah.
my voice audible? Before, because I will also tell the financial benefits of this project. But before saying that financial benefit, we are because we only measure the success only by showing the financial benefit, but there are some social benefits also. Before mentioning the financial benefit, I will tell about some social benefits. Just in my nearby shop where I started that work, the most two of the sevikas has been approached for the election to fight for the sarpanch election, and they politely refused and says they are happy with their social work, said they don't want to enter into the politics. Many of the one of the sevikas was forcefully entered into the this elections, and she didn't what you'll say, she didn't go to the booth and all. She was not interested at all, but still she got around about 120 votes from out of 500 without any what you'll say prachar, or but without any advertisement marketing. She already get 120 votes, but she didn't win the election. But she was not interested at all to win it, but still she got 120. These are some benefits of they have got social empowerment of that. And when we talk about the financial benefits, uh, we also have to understand that whatever Sevika was also incorporating money for his family, for her family, because she also had some health costs that she also is saving now. That many of the Sevikas had already patient of lifestyle diseases in their home only. Before she used to go to get the test done, and she usually spend it five. Their family spend it 500 to 1,000 rupees, and that is also now saved by Sevika for her family also. That also implies that money saved is money earned, but also there is money earned from the other patient also. So we take very minimal, like 10 rupees, 10-20 rupees from the patients. Still, Sevika is able to earn. There are different ranges. Minimum range is 1,000, and it is goes up to 7,000 rupees, Indian rupees. So, but I know it is not much for anyone, but for a rural population and for especially for lady, it is a game changer for us. And because we have, I can tell you all the data till date. We have right now our live dashboard is going on. where I have now encountered 34,633 patients. That when you convert that into money, that will be money saved will be like around about 13 crores. So we have already saved 13 crore rupees. We have made Sevika to earn around about 1,000 to 7,000 rupees. So, and Sevika is also saving money on her patients, her family encounters. There is a Sevika that have three patients of high blood pressure and sugar. She had to spend 7,000 a month on those patients. So she's very grateful for that. So that 7,000 is being saved by us. So that is also a part of our success. Thank you, ma'am. Over to you, ma'am.
Currently, there is, I must
And
make mention of
Dr. Mehta
this,
and
that in a, sorry,
yeah, I had one last question for you. I mean, we talked about rural India, but I'm sure there are lessons for the other G20 countries who are also kind of listening and watching this on mainstream and live stream. So,
yes.
what would you kind of recommend for countries which are like Africa or maybe like Cambodia, etc., where we still are kind of having similar kind of problems? So, any lessons learned, any best
Lessons,
practices?
yes, yes, big lessons. It's not difficult to reach out to unreachable places.
Yes.
Technology makes everything possible. And tradition should be our strength, it shouldn't be our liability. Darkness is removed by light, and so ignorance can only be removed by education. I think we need to run modules similar to what we are doing, because we are not only changing the shape of villages, we are also changing the shape and the outlook of people who are living in these villages. So, lessons to the other countries who would probably be following suit would be that we tailor make these applications, these programs to the needs and to their geographical areas necessity. We study their government setups, the way they are their delivery mechanisms. We work in partnership with the government and with some external aid. But most importantly, I think bringing education to the women. She is the sun of the family, the SUN. So that's where all the energy comes in. And I would really say that there is nothing that can be not done. No is a non existent word. Uh, for Cambodia, for South Africa, for maybe Indonesia and the interiors in their fellow countries, the humans, the women there are as women as me and you, Simi. And probably we just need to work out programs, and you know we have to work on the same modules over there.
Sure. So, Dr. Mehta, would you like to add something to what Dr. Vani said, specifically when we look at cost savings and data access?
Far as this thing is, our this program gave a very good impact on the society. Uh, a condition was like that lady was not in position to identify herself, as Vani Didi already said. Other in other sense, if we say that she was not in position to talk to anybody, but now our sevikas, they are so competent that they can talk anywhere. Even as a speaker, they are speaking in this thing. We are organizing annual this concerts also. There they speak and they give their experiences. They give a good talk also. We are giving them some topics, and on those topics also they are speaking. So this type of thing is there in the villages. Our this actually Sevika is not Arogya Sevika, but she is our health activist in that area. And as an activist, she is working in that area for the upliftment of the entire village. And she is looking after entire village as an health activist. And her activities are truly speaking giving a very good impact. as you asked this to Dr. Vani also this question, that what for the other countries, I would say that our the same model is actually applicable everywhere. Wherever you are having will, there is always way. So when we are going with our will to improve that village, we are getting definite impacts. And many times we are moving in those villages also, and we see that how their behavior pattern is also changed. The shy girl of the shy lady, rather not girl, actually our Sevika is a married lady of that village, because we select the married lady so she can support her family, as well as she will be with us for a long her lifetime. So that's why we go for a married lady of 10 to 12 past in that of that village, and we are training them. After training, they are giving fantastic results, and we are happy with their this improvement. And our tries will continue till we go ahead for this thing.
Thank you, Dr. Mehta. Thank you.
Yeah.
Dr. Manish, I'd like to ask you to give us some concluding remarks. Specifically, I would like you to focus on the challenges.
Yes, ma'am.
That you
One of
face.
the
Yes.
challenges is Yes, ma'am. One of the challenges is the financial part, because the money is reside, as all of us knows, the money part it resides on the urban side, and the motivation or skill side. I'll say one of many of the person has visited our site who have already encountered telemedicine. They tell us that your Karyakarta lacks in skills sometimes, but motivation, haven't seen such motivation in any of the Karyakarta till today. But what we lack is the financial part, and what we lack is the, in some aspect, is urban involvement. So I'll say when the people from urban side also involve more in this, then the public from the urban side will be more and more engrossed in this, will be helpful for them, because that would be a greater help for us also, because urban people have great skills, have great money, whatever they required in their skill transfer. So I'll say connecting to the urban people to the village, that will solve many of the problems that I can see.
Thank you. Thank you so much, Dr. Manish. That was a really great insight. And we would have thought that, perhaps that disparity that we see is rooted in actually the rural side, but it seems it's the interest from the urban that nearly needs to actually increase. So thank you for sharing that insight. Dr. Vani, I would now invite you to close the panel. We have about 2 minutes to go.
Okay. Thank you. Thank you so much. So this has been overwhelming, and it's been a great journey over the last 60 minutes or so. 60 minutes yet to get over. And I would just like to make a loud appeal out to all those people who are watching us from across the globe. It's not difficult. It's not impossible. Moving partnerships between an urban and rural areas, people partnerships, is what is going to move economies. A country cannot be known uh, by the cities that she has. A country is going to be known by the development that happens in her villages. The cities are going to be self-sustaining. It's the village where we need to focus on. For people not from India, villages would be the countryside. Let's develop our countries and let's push this forward. Thank you so much, Simi. Thank you, Dr. Mehta. Thank you, Manish. This was beautiful.
Thank you, Dr. Vani, for pulling such a wonderful panel, which is rooted in the grassroots, but has got aspirations for India to actually kind of hit the ceiling. Thank you so much. Thank you, Dr. Mehta. Thank you, Dr. Manish. Thank you, Dr. Vani.